Good morning, everybody, and welcome. It's the 2nd of March. Welcome to our formal meeting of the Lancashire and South Cumbria Integrated Care System Board. Today we have a formal meeting. There are a number of members of the public and other observers joining us. You're all very welcome today. Thank you for your interest in the business that we do. If I could ask the normal protocols for you to keep your camera and microphones turned off, and to respect the fact that the text column is a part of the meeting and is there for members of the board to use to contribute to the meeting. I have a number of notified apologies for today.
About us.
We have apologies from Tracy Hopkins and Angela Allen, and as you remember, Peter Armour, who served this board with very well for a period of time as the lead from the VCFSE. Peter stood down from that position, and Tracy and Angela both to attend here to represent the sector, but unfortunately neither can make this meeting today. I've also apologies from Dennis Gitsey, from Eileen Fairhurst, who attends as the lead trust chair from the PCB. I'm delighted that Ibby can join us in that capacity today. Thank you, Ibby. Jackie Hanson and David Blacklock, who represents Health Watch, complete the apologies. Two attendees to welcome. I'm not sure if they're right on the call yet. Professor Raymond Fitzpatrick, Professor of Public Health and Primary Care at University of Oxford, will observe some of the work we're doing, and Helen Crocker, Senior Research Officer, again working with Jane Scattergood on some of the quality system development. So we welcome. We've a full agenda today. I'd just like to make one or two announcements before that, if I can. The legislative process to the new health bill, which establishes the new integrated care boards and all the associated architecture, and ends the life of the CCGs. The planned date for these changes to take place is on the 1st of July. However, this remains subject to legislation. That process goes on. We continue to work flat out to be ready, well ready before that date, to take on the new statutory business. There's some notable changes as the process has gone through the latest stage in the House of Lords. One of which is that it had previously been determined that if any elected member, a member of Parliament or the European Parliament or any local authority, could not be a formal member of the ICB, the Unitary Board, that restriction criteria has now been lifted. I welcome that because it's an important signal and an important part of the discussion for us with our local government partners as we go forward, that elected representatives have a vitally important part to play in the development and the leadership of our health and care system. The health and wellbeing boards are still there, playing their crucial statutory role in each of the upper tier local authority areas. The responsibility for joint strategic needs assessment remains firmly there. the connection with how our place-based partnerships developed with the health and wellbeing boards and other parts of local government is very important, and we're working through all of that as we consider the place-based arrangements. The integrated care partnership, Andrew might touch a little bit on this later in the meeting, is the place, I think, where crucially some of the key strategic issues around population health, health improvement, and the priorities for our system get considered. And I think that this is a place where our colleagues in local government, members and officers, come together with parts of the health system in order to work collectively in true partnership on those changes. And what we need to continue to work on is how the membership between the Integrated Care Partnership and the Integrated Care Board connects, so that we can recognise the different roles and different composition of these two bodies, but recognise that the way that they work together will be crucial to the effectiveness and success of our system across Lancashire and South Cumbria. In the meantime, we continue to operate in this form, and some of our business will go down in the new world, we'll go into the ICB, and other bits of our business will go into the ICP. We continue to be a hybrid of those things for an ongoing period until the new arrangements can operate in shadow. Obviously, for a period of time, I've been and remain the designate chair, subject to the formal establishment of the body. Our designate chief executive, Kevin Lavery, will start in post later this month. We've announced some designate non-executive members of the new authority, and this includes two people from this board, Roy and Ibby, and I'm absolutely delighted that they've agreed to join the new ICB. They like me and Kevin, are designate non-executive members at this stage. We've gone through a process of appointing some of the key statutory executive director posts, a finance officer, a medical officer, a nursing officer, and a people officer, and preferred candidates have been identified. There's no further announcement to make about these appointments at this stage. It's all subject to contract and agreement and so on. It's going through proper process, but hopefully we'll be in a position to make some announcements about those vitally important posts in the coming period. So we've a designate chair, a chief executive, non-executive members, making good progress on the statutory executive director post. The bit that's still missing is the partner members. And you'll remember, I think, that the constitution that we've discussed here before includes a category of partner members, full members of the unitary board, the equivalent status, role of the executive and the non-executive members. And we're to have 4 partner members. You'll recall 2 from NHS trust providers to ensure that we can cover the full range of services, acute, emergency, community, mental health services. So there'll be a partner member at the seat at the table, expert in one or more of those areas. We'll have 2 members. We'll have a member from primary medical services for general practice, and we'll have the member from local government. It will be a social care providing local authority, and there's a nomination process to go through for each of those 4 partner member roles: nomination, selection, and the details of how that process needs to run will, I expect, be set out either in the bill itself or in underpinning regulations, and that work is still ongoing. So at this stage, we're waiting to start the process to appoint the partner members to the board, and that's not going to, I don't think that's going to start imminently while that body of regulation gets developed. So we won't be able to get to a full designate membership of the new board for a little while yet, and it's vitally important that we get the process right to lead to the best outcome we can for each of those 4 partner member seats. It's a new dynamic for an NHS board, or certainly the ones I've ever experienced, where more traditionally we've had just executive and non-executive members, but in this system leadership, the partner members will play a vitally important role, and I think will bring a significant contribution from, if you like, the other part of their professional life, whether that be in local government, in primary care, or in NHS trust provision. That live current experience straight into our boardroom will add significantly to our capability to do business well. So that's where we're up to at the board, and we touch on it in the paper later, but I just wanted to explain where we're up to. What all that means is that in the meantime, we'll continue to function as this board and consider over the coming weeks how we can transition from where we are now into shadow arrangements for the partnership and the new ICB, and we'll work together on that as we go forward. So we've an agenda today. The core part of our agenda today is a very wide-ranging paper on infrastructure. It covers digital, net zero, building standards, the built environment, the broader issue, very broad consideration of issues around infrastructure, and there's a great depth as well as breadth in this paper, and important issues in there for us to consider. Before that, we'll look at the process for the plans, our operational plans for next year. This process is a bit more messy than it otherwise would have been, with us potentially switching the statutory arrangements around after the first quarter of the new business year. So there's a complexity to that we need to be mindful of as Sam takes us through the plans. And then we've an important update from colleagues in terms of the mental health, learning disability, autism developments across our patch, and in between that, the regular update on aspects of setting up the new system. So we'll crack on. There's a lot for us to cover today. With the minutes of our meeting of the 12th of January, when we met formally, actually, I need to record in the formal meeting a declaration Isla made previously in a private meeting, that she's now the chair of the Cheshire and Wirral Partnership Trust. No direct conflict being in another ICS area, but important to be noted for the record, and congratulations to you, Isla, on that appointment, which I know you've already taken up. I've not been notified of any other declarations of interest or potential conflicts as always, please, as we go through the agenda, if you feel that you're in a situation where your contribution could be interpreted based on some aspect of conflict, please just make us aware of that. So let me come back to the minutes of the previous board meeting, 12th of January. It feels a long time ago. We were in the absolute eye of the winter pressures at that stage. We had a long discussion about what that was doing. I have to say, we're not out of the woods, but it feels to me that things have eased somewhat. I think both in reality and also the sense as the days get a bit longer, it feels that we're coming out of the intensity of that period. And I think that across our primary care sector, our hospital sector, our community service sector, under great pressure, people continue to respond phenomenally, and the care that you were able to provide, and both in terms of the access to care and the pathways of care that we were able to maintain, continuing with our elective recoveries, of huge credit to your leadership and to the many thousands of people in the teams that work for you all across our ICS patch. So can I propose that we accept the minutes of the last meeting, please? Someone second those for me.
Formally second those, Chair.
Thank you all very much. And Andrew, over to you.
Thank you, Chair. Two messages this morning, two areas to cover. One that relates to a Care Quality Commission inspection of our local services, and the second relating to the white paper on integration, if I may. So firstly, we received an indication about 10 days or so ago that the CQC would be conducting an inspection of urgent and emergency care services in Lancashire and South Cumbria. And they're doing this on the basis of multiple organisations. So they may not go to every hospital, but they are going to choose a select group of hospitals, general practices, ambulance services, potentially mental health and community services, GPs and dentists, among others. And selectively, they are going to conduct inspections of our urgent care services. So linked to your earlier point, David, about coming through the pandemic period and the winter period, we're now very mindful of this inspection process. The CQC at this stage are indicating they will inspect providers in a familiar way, looking at a number of key lines of inquiry. But in addition to that, they'll also be making an assessment of how we have worked as a system. And so that's a particular approach that they're now using to system-based inspection. We are using our joint cell arrangements, which we've maintained throughout the winter, to help us to coordinate and forward plan for this period of inspection. We believe it will start imminently and go through to the middle of April. CQC made us aware that they will publish individual inspection reports for individual organisations, and then they'll also give us a system report. And so as that comes through in due course, we will respond to that. We will share that with the board, and it will be an obvious focus for learning as we come out of this winter period. The second item, I just wanted a headline before we speak about it in under item 9, but the government have published a white paper around health and social care integration with a subtitle, Joining Up Care for People, Places and Populations. This was published on the 9th of February, jointly sponsored by the Department of Health and Social Care and the Department for Levelling Up Housing and Communities. So it's an important paper at this time. It is connected in some respects to the Health and Care Bill going through the Commons at the moment, going through Parliament at the moment, and it raises a number of proposals and asks for responses in a consultation process around those issues of how we continue to integrate and improve the services people receive. So there are areas of focus in the white paper around outcomes, around financial arrangements, accountability, workforce development, digital and data. Now, I am making an assumption that individual organisations in the system may wish to respond to the consultation period. That's running for 8 weeks up into the middle of April. But I just wanted to indicate we will, through Carl Ashworth, propose an ICS response to the white paper so that we're able to contribute our perspective to the range of consultation questions that are in the document. So we'll touch on it again in item 9. There is a summary of the white paper proposals in your pack, but I wanted to headline that at the beginning of the meeting. Those are my key messages today, David. Thank you. Thanks very much.
Thank you, Andrew. Any points or questions for Andrew before I move on, please? Okay. Thank you, Andrew. Sam.
Thank you, Chair.
Hi, Nancy.
Sorry. Thank you very much. I've actually put in the papers the month 10 position, the financial position. So I'm going to take the paper as read. There isn't a lot of difference really from the last paper that you've seen, in that we are on track to meet our financial targets this year, and we're expecting to land with a balanced position. And I say that quickly, but actually there's a huge amount of work that's gone into that, and it's a real credit to all the organisations that have worked together to sort of get to this point in the year. But that continues, and I think as with the CQC issue that Andrew raised, I think it's really similar on finance. What we're seeing as we're coming out of the pandemic now, much more focused from national teams and regional teams back on the finances going forward. So I think going forward, this report does show that we are balancing at the end of the year, but actually what we can see in it is there's an awful lot of non-recurrent action that's enabled us to do that. So when we go on to the planning paper in a moment, I think a real focus coming out of this year and going into next year is the fact that we absolutely need to start to embed those recurrent schemes that we've now been developing through this current year, and making sure that they're landing in time for us to be able to drive out the savings that we need going forward. There's going to be an increased focus on some of the areas that we know are pretty hot spots for us across Lancashire and South Cumbria, including a focus on agency costs and our rates. So the work that we've been doing across the system has been really important in helping us put the plans in place around that to drive those costs out. So I think that's probably, I don't want to go into any detail on the paper unless people have got questions, because I think it is more of the same message, but I do think it's a good position for us to be in at this stage. The focus now going forward will be that recurrent and maintaining the delivery to find long-term financial sustainability for the system.
Thanks, Sam. I'll take questions first to Graham.
Yes, I just wondered, Sam, I do understand that the acute sector has opened up a deficit of £170 million, and I wonder how is that being tackled, and is it a danger to us?
Thank you. Yes, I think what we've seen is sorry, I'm just getting some echo. If we could mute, it'd be helpful. Thank you. Yeah, so I think what we've seen is in 1920 the system delivered a system deficit. It's a reported deficit of around 170 million, and that's in all the published accounts. And we've seen that during the sort of pandemic, we've been supported with funding to get us through the last period to support the system, but there's been an awful lot of work to try and address that deficit. What we're doing at the moment is that's being addressed through a number of non-recurrent actions. But I think what we're doing as a system is coming together very much. Some of the work that we're doing in provider collaborative and across the system and developing the strategy going forward around our clinical vision and corporate vision will enable us to take a longer term view of how do we transfer some of that non-recurrent action into the recurrent plans that we're going to need to achieve long-term sustainability. But this Graham, isn't about just driving money out. This absolutely is about improving quality at the same time, which is why we're taking more of that sort of strategic and more of a transformational approach to ensure that we're meeting our quadruple aim and driving up quality and better outcomes at the same time.
Thank you.
Kevin?
Thanks, David. It's not it's a question, but more just a comment.
mean, this system's been in financial deficit for many years. The fact that we're now coming towards the end of this financial year and the system's on the month-end figures is forecast to be in a break-even position, I think is a tremendous effort from everybody in the system. It shows real leadership. And I think we should just give credit to the people who are being responsible for really pushing this financial strategy through. And really our FDs and our finance professionals have done a tremendous job holding the ring in really difficult circumstances. So I think we should be really proud of the work that we've done on our finances. There's a lot more to do, and as Sam says, we need to deliver this on a recurring basis. But, you know, this is a good place to be at this point in the year.
Thank you, Kevin. Well said. And to Aaron.
Thanks, David. I absolutely echo what Kevin said. It gives us good confidence that when the system comes together under a different banner, I remember the conversations about the H2 plan going in and how difficult it was to kind of work through getting to a balanced position and the risks that we faced. And it's the joint risk management and the ownership of the delivery that's got us to this position. I just wanted to respond to Graham's comment at the end of his question, which is that, is this a danger to us? Because it's quite a specific comment to make. And I do think in terms of what's the impact, having a deficit like that, what does it mean for us as a system? Now, it absolutely points to areas of inefficiency or non-productive work in areas that we know that we've got issues around long waiting times, around quality and safety exposure that the CQC have highlighted in a number of partners. So not a danger to us, but it is pointing us at a number of areas of improvement that we need to kind of bring more to the fore, I think, when we talk about our transformation plans. And the other thing it does for us, Graham, is it's a significant contributor to whether regional and national partners are confident in this leadership to be able to apply for things like the new hospitals programme business case or some of the work we want to do on transformation programmes. So it's really critical that we continue to build that confidence. So when we talk about the deficit, yes, it's financial, yes, we need to bridge it, yes, there'll be cost improvements, but there are two lenses by which we need to look at this that should escalate, I guess, the importance for us as a board on continuing the good work that we started now.
Thank you, Aaron. Right, Sam. So we're going to finish the year where we said we would, which I endorse the comments that Kevin and Aaron have made about the significance of this. But now we have to put plans together to ensure that we continue to improve next year. Do you want to take us into that paper, please?
Yes, I will do, Chair. Thank you. So lots of work going on across the whole system involving a number of you and your teams across the system on developing the 22-23 plan. I'm not going to put the slide set up, but I'll just talk through a couple of the slides. I think probably just to be clear about the approach we're taking, I think it's a good approach in that sort of Gary and Carl have been pulling together an operational planning meeting every week for a number of weeks now, which includes all of our planning programme leads across multiple headings, but also our place-based leads as well. So it's been a sort of matrix approach to that sort of planning meeting, which is really starting to look at what are the must-dos in the plan, what's the narrative, how do we pull that together. In addition to that, there's been a number of conversations with our local authority colleagues, and I've had conversations with, and I think Angie's on the call, but with Louise Taylor, but I know that Carl and Gary have been attending some of those local authority meetings to really understand the joint agenda that we share, because a lot of the plan is about that how we address inflow, how do we continue to do the good pieces of work we need to do together for our population. So there's a lot of work going on around that. In addition to that, the provider collaborative have also taken a view on the plan and working really closely together on some of those strategic elements of the plan. So thinking about we're accessing additional capital over the next 3 years for our elective recovery and for community diagnostics. How are we taking a more strategic approach to that? And Provider Collaborative are giving a view on that and some of those priorities to make sure that we're sort of working really well together. So there is some really good joint work going on across our providers in those areas. And on top of that, the finance directors are meeting every week at the moment to go through the plan as we're starting to pull together. We're just working on a first cut of that plan, so it's early days to bring any figures, and needless to say, it's going to be a challenge, but there is a lot of work going on to sort of look at how do we submit a balanced plan, which is one of the key principles of the planning work that we're doing. So that's sort of the approach we're taking. What we're just trying to do today is to give the board a real sort of sense of what that planning approach is, what the framework's looking like, and the sort of financial principles, and how we're going to take this forward to submit our draft plan and then final plan. There is a timetable in the pack which does show that our draft plan needs to be submitted on the 17th of March and a final plan at the end of April. What we've done from a financial perspective is have cut off at the end of this week to look at that first cut properly and to have a look at that next week, so that we can understand how that's starting to shape up and how we're sort of looking at delivering all the must-dos in the plan and the investments, but maintaining a balanced position. So that work's going on currently this week. And there's one slide in the pack which gives an overview of the sort of the 10 priorities nationally that have come down into the operating planning guidance. And I think the work that Carl's done in demonstrating this visually is really helpful. So the actual slide shows you how the 10 components of the plan align to the ICB aims for the future and what approach we're taking. So it covers the areas sort of looking at, to start with, at how are we establishing the ICB and what work are we doing collectively in the system, and then moving into tackling those health inequalities and outcomes through the population health and responding to COVID, and then actually getting on to sort of the productivity and the value for money, so looking at our workforce, digital and use of resources, and then looking at the outcomes, particularly highlighted around with a focus on elective care, urgent care, mental health, and timely access to primary care. So they're the key areas and they're the 10 components of the plan. And so what we're doing is structuring all of the planning around those and making sure that they absolutely link to our strategic approach in the ICB. So the outline to that sort of plan development is outlined on one of the slides that shows you how we're doing this. I think what's going to be really important in this is we do know that through the allocation, the financial allocation that we're being given for next year, because our allocations are going to be based on last year's cost, or the year before's costs, sorry, H2 costs, we know that we are going to be above our fair shares allocation, and so there's going to be over the next few years there's going to be a push down to reduce that allocation through a sort of like an efficiency requirement each year. So what we're trying to do is set some real principles going forward around how we're looking at this and how do we recognise the financial constraints in the system. So what we're not doing is going out to all of our planning leads and saying, you know, what do you want to meet these targets? We're actually asking people to say, how can we work creatively, given our baseline and given where we are and given our financial constraints and workforce constraints? How can we work together, even with the new investment coming in, to make sure we maximise the value for money in everything we're doing? And that's a really important principle of the way people are working, because we know that as we go into next year, we're not going to be looking at run rates that are going to be going up. They're going to be flat, and that is the sort of national picture. So although there will be new investment coming down, we have big efficiencies to make, and we need to think about our productivity in our workforce and the way that we're working across the system in the way that we're delivering this plan. So that's been a big emphasis through all of the work that Carl and Gary and myself are doing in the system. In terms of the financial principles, we've been really clear that the absolute deliverable here is a balanced plan. As we mentioned before, it's been fantastic that we've been able to galvanise the system and meet the numbers that we've needed to this year. And the national team have really sort of, you know, I think been quite pleased with the progress that we've made around that. And as we've said before, this will put us in good stead if we continue to show that progress. It'll put us in good stead for future investment and development, particularly around things like the new hospital programme. So the principles are really important, and so submitting a balanced plan and sharing that data has been a key part, and all organisations are working together to do that, which has been really good. And having what we're trying to do is build in some kind of top slice to support our future transformation. So the System Recovery Board has been coming together to look at both short-term things that have supported the delivery of the plan this year, but also what are those long-term aspirations to deliver long-term financial balance. And those sorts of things are having that single approach to a clinical vision and looking at where we're inefficient across our clinical networks, but also how could we work smarter across our corporate functions. But to do that will require us to pump prime that transformation. So we're asking for an inbuilt amount to be top sliced from the allocation to support transformation in there. And we're just working through what that might look like. Also, we need to make sure that we are pulling in all of those system-wide opportunities, and all the organisations are now, we have a mechanism for all the organisations working together to identify and pull in those opportunities that are supported by the diagnostic work that we undertook earlier this year, so we can see what opportunities there are, and they're pulling those into the plans. And I suppose that the other key thing I'd probably pull out of that is just thinking about understanding sort of the timing of the investments and the full year impact. There's no point in us saying that we're going to start things running from the 1st of April if they're not going to happen. So we're just taking a bit of a view on that. So what we've got built in just before the first draft goes in is a senior leader exec check and challenge system, where we'll be bringing that draft and having a conversation about it. It is a draft, but we want it to be as close as possible to the sort of output that we'd want to see from the final draft. There will no doubt be more work to work up the detail between the two submissions, but we want that to be sort of a real check and challenge session to involve people and look at the plan and ask questions before it's submitted. So today it was just really to note that process, note the timeline, to sort of be able to give you a bit of an overview of that planning framework and the financial sort of principles that we've put together, and just to let you know that we've got that SLE session in to look at the plan before it's submitted. So I'm happy to take any questions on that, and Carl's here if there are any other questions as well on the planning process.
Thank you, Sam. I've got Ian and Jeff.
Thank you, Chair. I'm just looking at your slide. It's on page 23 of the pack, and I'm obviously focusing on financial plans. And you're saying the slide, our financial plans balance recurrent SIPs with new investment. That's fine, I can understand that. Our workforce plans are realistic and affordable and deliver sustainable, resilient and flexible, healthy workforce. I'm not sure that's right. And I'd like you to just expand on that if you could, because I'm not sure, unless you get a grip on the workforce, you're going to address your recurrent imbalance in the system. And I haven't seen a workforce plan that is transformational at the moment. It all seems to be reactive rather than proactive. And if we don't get a grip on the agency spend, I'm not seeing any plan to do this, we're not going to be able to deliver our financial strategy. So the question that I've got for you is it transformational enough? What else could we be doing with reference to other healthcare systems that are better than ours and work better with the workforce? What are the risks involved, and have we got those risks under control?
Thanks, Ian. Sam, I'll come straight back to you before I go into others.
Okay, thank you for that. Yeah, and I agree. We've got to get a really clear plan around our workforce. What we are doing through this planning round is to ensure that we're triangulating the workforce with the activity and the finance to ensure that they're all in line and they're balanced. I think obviously we're developing our strategic plans, and I think what I'm describing is we need to take more of a transformational approach to all of our clinical strategy, our workforce strategy, and that is what we've started to do. Obviously there's more work to do on that, but I think the agency work, I would argue that actually is there has been an awful lot of work done around that, around rate cards and looking at how we had again at the provider collaborative meeting this week work more on medical as well as nursing around that. And I think this is an area where we know we are really inefficient. We're an outlier and we need to do more work, and I think that work's happening. We were making good progress on agency spend coming down before before Christmas, and then we had the Omicron issue sort of in January, but actually very quickly we're pulling that back now through the work that's being done across our HR colleagues. So I think there is work being done on that, but I do agree that I think the workforce transformation, we need proper workforce planning, and we need those new roles, and we need to look at how we're working differently, and that is a key part of our journey, I think, going forward. There may be others on the call that would want to comment on that, but obviously I think that is a key part of our transformation work we now need to do.
And Jeff?
Thanks, Chair. Thanks, Sam. My question's about primary care, and I'm looking at the financial principles, and the context that I'm going to say is this is a public meeting, and so this will be seen maybe by some in primary care, and I do not doubt your understanding your commitment to primary care, but I'm looking at the words in the principles, and I'm looking at the 5th line, which says continue to contribute to fund all people to provide a collaborative support, which again goes without saying. I'm happy with that, but my colleagues might say, and where's the support to primary care? So where is it?
Yeah, I can understand that. I think what we're describing there is the work that the provider collaborative has been doing this year. They've pulled together a fund together to work together as a group. So that's what that relates to. I could probably do with actually clarifying that in a more detailed way for you, but I think that's what it is. So each of the trusts that are working in a provider collaborative have put a certain amount of money and some people forward to help with that collaborative working, and it's not new resource. It's more about them working together and pooling their resource, and that's what it relates to in there. But the primary care support, obviously, the whole of what we're doing in terms of pulling together the structures and the way of working, and thinking about the new ICB structure going forward, about how we support place and how we support colleagues, will all be part of that, along with the new investment coming into primary care through the SDF and other mechanisms. Can
I come back, Chair?
Yes.
Yeah, I mean, I suspect there's similar amount of monies tied up through CCG support to primary care in place, and it might be helpful to pull that together and identify it and say that might be protected and used to support primary care. I think that would go. So I'm not saying there should be new money. I think it might be helpful just to identify that.
Yeah, we'll do that. Thank you very much for
that. Peter, then Martin, please.
Thank you, Chair. Just wanted to flag up a limitation that we've encountered in the planning stage this year, which I think is important to note at this board. So the primary and community care subcell received the operational planning guidance weeks ago and felt that there were obviously areas that were very specifically relating to primary community care that we would be writing, but large areas of the planning guidance we felt we could really contribute to in the spirit of the integrated working that we're trying to achieve. And it's fair to say underwhelmed by the ability to do that. Now some of that may well be simply pragmatic difficulties in getting the meetings arranged and what have you, and so I think that was largely the issue, but I think there's something that we can learn in terms of how we approach this year on year to ensure that we have truly integrated working in this planning writing up. Otherwise, we're going to miss those opportunities year on year to really do the integrated working end-to-end pathways that we need to write up. So just wanted to acknowledge that here, because I think it's a strong learning piece for us.
Yeah. Thank you, Peter. It's a very important point. Got Martin, then Roy.
Thanks, Chairman. So very much support the process you outlined, Sam. Just focusing on the elective care bit, which is going to be really challenging. You know, we've had that elective care recovery plan. I know we've been given help from KPMG to work with the elective care recovery group. Have we had any feedback from them yet in terms of, you know, that plan?
No, we've not had any feedback yet. I've been to obviously the meetings to set out the work they're doing, and their work is predominantly around the demand and capacity modelling, which will help us then to model through the activity and the workforce and the funding into the plan. So it will be coming out as part of the, obviously when we get the draft plan, we'll be putting details in around that, but I haven't seen any output yet. But this is part of the national agenda where they've provided some support to each system, and KPMG have been given to us as some system to do that modelling, which we're grateful for, because I think hopefully it'll be the piece of work that we'll need to feed the plan.
Thank you.
And Roy?
Thanks, Chair. Just to refer to the slide with the 10 components of the plan on, Sam, and thanks very much for the presentation, by the way. I think it's really good. But one of those components is about digital technology. And I think one thing that the pandemic has taught us all is that digital technology is the way forward, certainly in terms of how we talk to our patients and how we receive information back from those patients. I was a member of the Digital Health Board for some time, and we talked about shared care records. And I noted this morning, I saw a headline this morning that's saying ICSs might be asked to converge their electronic patient records, which is an interesting point, I thought, and I think probably welcomed. But I remember the discussion that we had on that Digital Health Board, and the acute trusts, I think, have different contracts with different providers of their electronic records, and those contracts start and finish at different times. So I think to pull those together, we found actually when we were looking at that, it would be quite difficult. Well, I guess we would all support it, and I think it's really something that we really need to push. And with local authorities as well, so we can have those shared social healthcare records. I think it's really important that we try to do that, but I think we might be stymied a little bit by the situation that we have within the acute trusts with regard to their contracts. Thanks, Sam.
Thanks, Roy. You raised an interesting point. I wasn't aware of the headline that you've seen, but I mean, this is a source of frustration to us, and I think that it's not just a question of a challenge of trying to converge everybody to the same place, but it seemed to me that we were making decisions that were going to take people further apart in the meantime. And I do think a truly integrated system depends on that portability and aggregation of systems, and the more that people are on common systems, the better. So I think this is difficult for us. My own sense, hands will go up because people will disagree with me on this. My sense is that it's convenient for us to talk up how difficult this is because it avoids us doing it sometimes. And I think it's a good time for us to reconsider the point that you highlight, recognising, of course, the contractual arrangements that different organisations currently work with.
I don't know. Oh, sorry.
No, just reading Kevin's comment, which puts me in my place. I've got Jane, then Michael.
Thank you, Chair. It's a specific tactical point, really, to commend to the board some really vigorous action on agency costs. The financial benefit's clear, but I think there's a real quality benefit to driving down dependence on agency. Colleagues who work for agencies are usually split broadly into 3 cohorts. Those that enjoy the variety, and they're very welcome. Those that are working 2 or 3 jobs and are shattered, and that impacts on quality. And those that are frankly working for an agency because they've been unable to secure a long-term substantive post. And that impacts on quality, and it's an uncomfortable truth. And I think the enablers that we'll need to put in place in order to reduce our dependency on agency will necessarily also drive up improvement and quality for our patients as we get to work together and have a system-wide bank. So just really a tactical point to commend that to the board as a real point of action in the next 12 months. Thank you.
Well done, Jane. Thank you. It's very important. I've got Mike, then Aaron, please.
Thank you. Sam, this is a genuine question. This is about the year ahead, but you've referred to long-term trends, and I don't want to preempt the conversation we're going to have on the white paper, but it does talk about pooled budgets and one workforce, and as Roy's just mentioned, the shared care record. So the question is, how does that longer term process fit into this? Is it something we've got to detach from this process, or do we take it into account as we evolve the plan?
Thank you, Michael. I think it's part of our future plans. This year, what we've agreed in terms of a financial framework, obviously we've got to take a bit of a pragmatic approach to rolling forward contracts, but actually this is year one of a 5-year plan. We're going to be developing longer term plans, and this is really quite a transitional year as we move through the first year. What we are doing is having those conversations with local authority, and as places developing and we're thinking about that sort of financial framework and how it flows through, we need to be thinking about how do we align budgets where it makes sense, how do we pool budgets where it makes sense, because we need to be working closer as a system, and these are going to be all enablers to enable us to support our population better. So it's definitely part of the plan. I think we'll get so far this year in terms of, you know, sort of pulling the plan forward and rolling contracts forward, but this year we'll be setting out, this is a first year of a longer term plan in which we'll be doing this jointly, certainly on a financial strategy and a financial plan. That's got to be jointly owned by all of our partners across the system. We all need to be working on this together, and that's going to be a key part of the work of the new finance director and the team in the next year.
Aaron, then Andrew, please.
Thanks, David. It's just going to come back to Roy's point, Chair, on digital. So I chair the ICS Digital Board, and it's been a reflective couple of months for us as a group about, so where is the strategy taking us and what have we delivered over this last period? And we've got some work coming into the SLE and the Provider Collaborative Board later this month, just to raise the profile again around the digital delivery plans and what the next steps are. And one of those programmes is the shared record. Now, we have committed as a group of provider chief executives to a single EPR platform, but this is going back probably 6 months, 12 months before the COVID pandemic started. So we've just re-engaged the Task and Finish group. We've appointed Gary Doherty as the lead SRO chair for bringing that group together. And just to address Roy's particular point, 1 or 2 of our organisations have had to, over that period, either recommit or recontract or set a new contract up with an EPR provider. But those contracts have been set up to be flexible enough to recognise that there's a procurement process coming for a shared platform. So, you know, whilst it's been a staggered start, there's a recommitment and a Task and Finish group established now on that, which we did just before Christmas, actually. So it's ahead of those headlines, but we'll bring it through to PCB and to board at the right time, Chair.
Thank you, Aaron, and to Andrew.
Thank you, David. It's just listening to a number of the different interactions. A couple of things about this planning process. All the meetings that I represent the ICS in, there is this sense of a kind of overarching question, which is, can you demonstrate to us that you are able to develop clear and credible plans? And that's why we're still in a process on financial recovery of having a regular dialogue with the national finance team, because they're still looking for us to demonstrate that. So some of the measures that we described earlier in the meeting are beginning to do that. And the importance of those financial principles that Sam laid out is that they give us a much more solid foundation for producing a credible plan going forwards, and it will provide a continuing acid test for us all. And just because Sam used the phrase long-term plan, just a nod to something that will come down the track in a few months' time. We understand that the NHS long-term plan is going to be revised, and that was a challenge when it came out the first time round, because it had been created with such huge expectation, with multiple priorities, supposedly over 10 years, but then the expectation seemed to be that we try and do it all within the first 2. So I think again, the way that we work together through these system planning processes and the way we prioritise is going to be a critical capability for us going forward. I'm confident that we're moving in the right direction. Don't misunderstand, but I think it's a continuing test of our actions as a system. Thanks.
Andrew, just while you're on, could you, in the principles document, we talk about 22-23 as the foundation year for our 5-year strategy. Could you just remind us as a board with the process and expectations around a 5-year strategy that all ICSs will need to produce? When does that become part of our discussion here?
We have we'll have to make a contribution to 2 strategies in a sense, David. There'll be one for the ICP. So that wider group of NHS and local government partners, and then as an integrated care board, we will have to pay due regard to that in the way that we establish our own strategy. So there is an interplay between different national expectations of us, either as an NHS body or as a wider partnership, and the interplay between that is going to need quite clear calibration. From memory, I think we have to have work underway by the summer on integrated care partnership strategy, but with a number of months to complete it. So I think, as Sam has been hinting, 22-23 is an important year for getting plans and strategies, and thinking about it as year 1 of 5 is a helpful frame for me.
Thank you, Andrew. So Sam, in terms of the endorsement of the principles and the process going forward, I think Jeff and 1 or 2 other colleagues have made important tweaks to the principles which we should build in, please. I always smile. It's ever been thus that you read the 10 priorities, and if you read in the bigger font, there's 10 things, and when you start reading the smaller font, you get to somewhere between 30 and 40 things that we have to do. I think the key to make this plan, as Andrew says, clear and credible for us, is to be able to set each of those things in the context of where we're at in Lancashire and South Cumbria, and what this means for our system, what it means in our places, and what it means in our provider system. And a good frame to come out of this will be, we're all clear what the different parts of the system are doing to contribute to the overall achievement of these objectives. So it's a good piece of work. Thank you. We've got the backing of the board to carry on. And when will you come back to us with the detail of what it all says and where the challenges are emerging?
Yeah, so I think on the 17th, after the 17th, when we've got the draft plan, we should be able to bring to the next board an update of where we are.
Thank you. Well done.
Thank you.
Now, Lancashire South Cumbria Infrastructure Strategy 2022. Gary.
Thank you, Chairman. I'll just take up a few minutes of your time just to clarify the status of this document and what Alistair Rose, our estates lead and the main author of this strategy, and I need from the board. So just a few minutes if you bear with me. So first of all, just the term infrastructure, when we've had discussions in the past about this, we're clear that we have to talk about more than just premises and facilities. So we need to talk about equipment, technology and digital. So we're trying to actually get the system talking about infrastructure as that all-embracing term. So this work is a culmination of quite a lot of work undertaken by colleagues from across our system over the last third of 2021, and it followed an estates and infrastructure conference held earlier in that year. It's been shared, reviewed and commented on by our colleagues across the system, and Alistair has ensured that comments and suggestions have been taken into account in this particular draft. There are some areas where comments perhaps were contradictory, so he's sort of, he's holding the pen, so he gets to decide what goes in. So we can't say that it will include absolutely everything that everyone's mentioned, but we think it's a good balance achieved around that. The document was considered by the Senior Leaders Executive on the 16th of February and endorsed by them following a similar discussion that we're going to have today on the status and purpose of the document, and I'll explain that shortly. One of the key comments that was made was to emphasise that we need to develop community infrastructure, because without that we won't be able to right size our hospitals as we go forward with that strategy. So that was one of the key things that was brought out at SLE. So just going through some key points that I want to emphasise. So this document summarises, I've got 6 points here: key information about our estate and infrastructure and the cost of achieving our aspirations. It contains our ambitions for premises and infrastructure, so that we can serve our patients, staff and population better than we do now. It identifies the principles we must use for the development of our plans and joint working. It identifies strategic issues like net zero carbon emissions and our emerging clinical strategy, and basically says that these have got to underpin all of the plans that we put forwards as we develop them in the future. It identifies the need to integrate thinking and plans for estates, equipment, digital, other solutions to achieve the synergies that we need, because if we don't achieve that, we've got less chance of being successful. And the final big bullet point I just wanted to mention, it actually identifies some of the big constraints we have, like capital finance and the expertise available to us. So in short, the document provides the background, context and the imperatives for the next stage of our short and medium term estates and infrastructure plans. It provides a necessary and hopefully welcome context for those who must now develop our plans covering the period 22-23 to 24-25, and it enables the forthcoming ICB and our partners to be able to assess the extent to which those plans that we are developing will fulfill the requirements that we've identified in the strategy. So it's not a plan as such. It doesn't commit the system to a particular course of action other than to meet the strategic requirements that arise from our own current estate and the estate and infrastructure, and meet the national asks. And I think the document will also serve to assure our regional national colleagues of our intentions and demonstrate that we have thought carefully about our strategy, and that will assist us in any small and large bids for capital that we will need to make as we develop those detailed plans. Colleagues, just a final couple of points. Colleagues from across our system are meeting tomorrow in conference mode. We will be meeting in person to agree our approach to the work required to develop our estate and infrastructure plans. So having this strategy document endorsed by the board as well as the SLE strengthens our ability to achieve a high degree of alignment across the partnership and ensure that solutions meet our strategic aims. The strategy will continue to be developed and change in the light of such events as we better understand our strategic challenges. So I'm asking the board to agree the recommendations and specifically to endorse this strategy document. And Alistair Rose, I hope, is on the call as he knows the document inside out. So if there are any detailed questions, Alistair can assist in answering those. So really what I'm asking is for the board to endorse this document. Thank you, Chairman.
Thank you, Gary. There's so much in this document. You can really generate a sense of excitement about where we could get to as you work through the different chapters. I've got a number of people who want to come in. I'll start with Isla, please, then I'll go to Graham.
Thank you. Yeah, it is a really exciting document. It's really nice to see it. And I note your comments, Gary, about where we are. I think it's almost impossible to create a document at the moment that keeps up to date with the national strategy. But I do wonder whether we can do a bit more on this to align it with the integration paper. Because whilst there are comments throughout it about system working, almost every example is about the NHS. And I think that misses it misses some opportunity. So, you know, when we talk about infrastructure, we could across the system be pooling and aligning budgets in different ways. We could be, for example, investing in portable technology for those of us across the system who have to be able to stream public meetings. And you know, and we could be doing much more about not just community buildings, but thinking about how we use our use of buildings and the way we pay for that to create sustainable income for voluntary and community organisations. So I think I'm very happy to endorse what's in it, but it feels to me very, very NHS-y in its intent, and I think that might not quite meet the strategic brief in terms of the integration piece. And then the bit that really struck me is I've really struggled to align this with what I know of the digital strategy. That is likely not a comment necessarily about this paper, but about visibility of digital strategy to this group. But when I read that and I read what I've seen in the digital strategy, they don't look like they come from quite the same place. And so I'm raising that for consideration so we can make sure that we don't accidentally have competing sets of priorities. You know, and for example, I would expect to see a really consistent line on what the system approach to hybrid working is. And they don't quite match up for me, which may well just be about what I've seen and what I haven't. So very happy to endorse it, but I think the next step is really making it system strategy rather than an NHS specific one.
Thank you, Isla. Great. Graham.
Yeah, I was going to make 2 points. The first point is very similar to Isla's point, really, about the one public estate. It does appear to be very NHS focused and local authorities, community buildings, other buildings, other services that we need to integrate with. And I just think that maybe in the next iteration, we can talk about how we can align our strategies with the rest of the public sector and the voluntary and community sector as well. So I think that point's been well made, and I hope we picked up. The second thing I was going to say was that I didn't get a sense of, in terms of principles behind the investment. I was pleased to see net zero and things like that. Well, I didn't get the strength of feeling around the importance of anchor institutions in deprived areas, and how the investment in anchor institutions in deprived areas can actually have a major health benefit in terms of employment, skills, training, education. That's so I sort of got the sense that our investment would be very much driven simply by what's the most efficient and geographically convenient locations, rather than sometimes the need to invest in anchor institutions in deprived areas, which has massive health benefits in all sorts of ways. So I'd like to maybe suggest that might be given an emphasis in the next stage of the work. Thank you.
Thanks, Graham. Very important. Alex, before you make your point, do you want to introduce yourself to the meeting, please?
Yes, Alex Heritage, Chief Strategy Officer representing Caroline Donovan from Lancashire and South Cumbria Foundation Trust. I'm also the Estates Lead, hence my interest in this comment. My support to the framework, I've obviously been involved with the team, and I wanted to build on Graham's point, which is just to strengthen that component around anchor institutions and our social value. I think we're seeing in more recent procurement that we can have a significant impact in terms of our local economies and our workforce. We have inflationary pressures, so I think I wanted to lend support to that being a stronger principle in the framework. But also, Gary, I had a specific ask, which the strategy references the complexity and risk of our PFI facilities in the short term, and I wanted to make sure that we approach those as a system rather than individual organisations, because actually, if I think of the concession periods that are ending in the near term, it may be as an organisation we may not want to follow it through, but one of our partners could, and typically we've addressed this individually rather than collectively. So there's a specific ask, which is, can we lead our PFI negotiations as a system now, as opposed to individual organisations?
Gary, do you want to respond to any of the points made so far before I bring others in, please?
Yeah, I mean, the issues that have been raised, certainly about anchor institutions and it being wide, it needs to be a wider strategy. I think those certainly I will take those points on strongly. I suppose the strategy, it's like a lot of NHS stuff at the moment. It sort of grows out of requirement that we've got to do something. The centre even had we're having discussions with Alistair about the template that we've got to use to do this, and we're not quite used the template that they provided, which would have made it an even longer document. In actual fact, that's not a criticism, it's all the things that they wanted in there. So I think you have to sort of draw the line somewhere and say, is this good enough? And ultimately, I think something like this, rather than the ICS board, is probably going to be something that we want to get through an ICP in the future, so that there is that sort of whole system focus. So it's sort of come out of the NHS, and we have. I think we've gone quite a long way to making sure that it's a bit more comprehensive. It doesn't just cover premises, and that there are aspects in there that we've identified for work with partners. But I think in the next iteration, and perhaps as part of our planning, we can take those comments into account that have been made by colleagues on this call. And, to some extent, that's part of the recommendations that, and I think Isla said it, this is a document that we're going to have to keep up to date. So the interactions that we have on planning and the comments that we receive from the various boards will enable us to remold this, so that it sort of, it ticks all the boxes and actually gets to the gist of what we're trying to achieve around that. I think the point about anchor institutions, yeah, absolutely. I mean, we've been quite clear about when we want to, I suppose, build these new facilities and such like, and through our procurement processes, we want to make sure that our local people benefit from the employment and the supply chain aspects of all of this. But if that hasn't come out strong enough, and I take the point from Graham, that what's the policy with regard to where one builds these premises, that perhaps needs strengthening. So we can take these on board and run them through the strategy to get another version of this. But for the time being, I'm looking, and I think Isla said it, looking for colleagues to say, there's enough in here to guide our current processes for capital planning and development of longer term capital plans. But we will take these points into account.
Thanks, Gary. I'll go to Kevin, then Jeff, please.
Thanks, David. I mean, the points have been partially covered, but just to very quickly, I think that this point about partner agencies being involved, I think a greater emphasis on place, I think, will be really helpful, because I think that's the point where it will come together and really focus on what we can do as systems and partner agencies. There, I think, will be really helpful. This is a really difficult document to produce, isn't it? I actually think it's a really good document. So well done to the people who pulled it together. But there's never a finish point, is there? Is the point? So we know now we're developing a clinical strategy. So I do think, and it's just, I suppose, that confirmation, Gary, that I think you're giving. We do see this as a live document. It's a document that probably needs to be updated on an annual basis, because as more capital becomes available, or we get clarity on capital, as we're clearer on our clinical strategy, everything will need to change, or a lot will need to change in this document. So I do see it as something that's live. I do see it as something that will need to be updated annually as a minimum. But I think it's a really good start. I'm very supportive of it. So thank you.
Thanks, Kevin. That's great. Just as an aside before I move on to Jeff, I saw, and others may have seen, a feature on the BBC News last night about the Rosemere Centre at Lancs teaching. I thought it was fantastic. And in the context, great facility, great staff, great story. And I focused a lot in here on the right accommodation chapter, the orange section, and I thought that story last night brought to life how important the right accommodation and the environment is for both patient experience, satisfaction and outcome on it. And it was a very timely, so well done Kevin and Ivy on that. I thought it was brilliant. I've got Jeff, then Roy, please.
Thank you, Chair, and thanks, Gary. I thought this was a great, very exciting presentation. We're obviously picking holes in it now to find the things that are missing, but well done on that. We should be excited about our future, really. I'm pleased to see that our Alfred Barrow Centre on page 31 there, because I tell you, I sweated blood and tears over 10 years in trying to get that into fruition and longer. So it's no easy task, and there's something I learned from that, which is what I want to return to now, and that's about the people who use the buildings, both the clinicians, the non-clinicians, and the patients. And the thing I learned, and I think there's something we need to do here, is and there's a lesson here for the estate strategy in general, and for the new hospitals programme. And I've had this conversation with Jerry before, I think, and that is, there's a great sentence in there somewhere, and I'm going to have to paraphrase it because I can't find it, but it says something like, when we plan buildings, we'll be mindful of the clinical strategy so that it supports the clinical strategy, which is absolutely right. But then it goes on to say, but actually clinicians need to realise the value and the opportunities of designing things differently. And I've seen many examples across. I've been very lucky to be transported to America and Europe, various places in this career, and see different buildings, and built the right design of buildings can make a real difference to your outcomes and how you achieve things for patients and the experience for patients. It really can make a massive difference. And the problem I had in Alfred Barrow was this: when I said that to clinicians, they said, well, give us the building, then we'll work out what to do. And it's the wrong way around. What you need is for the clinicians to have that vision of what they want to do if the building can support it. And it was really, really, really hard, almost impossible. In times, clinicians within primary care didn't get it. Trying to get clinicians across different professional groups didn't get the idea of working together or doing things differently. It's a real challenge. And I think in parallel to an estate strategy, we need some sort of development programme to work with the people who are going to use the buildings, and to learn how to work with the public about what they want out of the buildings. I really think that's an important parallel process to this, but I really like the presentation in general. Thank you.
Thanks, Jeff. Jeff took me around the Alfred Barrow Centre. It's a fantastic facility, and, yes, it also connects into, you can just about see on the photograph on page 31, an older building, I think an old school next door, which has become connected and part of the facility. It's a great environment.
Yeah.
And when you look at lots of the photos, the primary care centres in Blackpool and in Heysham, the harbour facility, we've got facilities at both ends of the quality spectrum within our patch. We've got some modern, fantastic stuff. We've got some things that you think, goodness me, how have we gone so long without investing in it? So this whole right accommodation focus, I think, is an important one. Gary, just on a point of detail, if you can wheedle a photograph of Jeff onto the photo of the Alfred Barrow Centre as well, please. Got Roy.
Thanks, David. Yeah. I've got some good photos of me actually outside our primary care centres in Blackpool as well.
Okay. Yeah.
Great document, Gary. Actually, and I'm pleased to hear that it's a living document, and we're taking it on board. All the issues that people are raising this morning, and the issues that Isla and Graham have raised about integration, I think is really important. And that's something that we've recognised over in Blackpool. We are building a new GP centre over in Blackpool, Jeff. That has involved the GPs. There's 3 practices going in there, but also there's a shared reception for social care as well. And I think if there's one thing that our patients, and our residents don't like, it's being sent to other buildings to say, well, you're in the wrong place. You need to go over there, the other side of town. We live in really difficult times, and people, don't have that capability of being able to move even across even small, short areas, short distances, I should say. So I think single point of access is really important, and something that we really need to consider when we're changing this document or updating this document, because where if people can go in and get all the information that they need at that single point, you know, they're not sent to other areas, then, and we have that either shared receptions with social care, or, you know, shared areas within buildings. Because you'll remember, Gary, we did an asset evaluation over in Blackpool, and we noted that some of our buildings, that we have quite a lot of unused space that we're paying for. So I think it's really important, you know, that some of that space we could use quite in a good way for some of our other integrated services that we're going to be putting into place over the forthcoming years. So thanks, Gary. Thanks for the document.
Thanks, Royce. Very good. And Andrew.
Just picking up on the comments about one public estate, I can see some references to it in different parts of the document. I know, Gary, we talked about it in relation to issues like meeting rooms between the ICB and local authorities, for example. But I wonder, again, as we carry on iterating this, whether there are some really notable examples that we already have, or that we could expand and develop further. Roy's just mentioned again the co-location of teams feels like an important one. So there's just bringing that out for us going through the next year, and making sure the ICB stands by this in the way it works with other partners too.
Thank you, Andrew. I can't see any more hands, Gary, so I'm not sure if Alistair's there either. There's anything that he wants to add. Alistair.
Thank you. Yes, just a couple of things, also picking up various points made. Some of the work with local authorities has come about and is touched on in sections 4 or 5, but could and can be developed further. Lancashire County Council are on with their own review, a similar review. It's got a different title, and in a similar way it's got a small section around the NHS in it, so we've started to input into that. As these organisations come together with their own plans, and this is the benefit of having a regular refresh of this document, you know, we can take this sort of document further and develop it greater into the anchor institutions that Isla mentioned, better use of the one public estate, which they're all looking at as well. So this isn't a fixed point document, as Gary has mentioned, but it's something that will grow and emerge as our partner organisations grow and emerge with their plans, which we will be involved with. Thank you, David.
Thanks, Alistair, and congratulations on a very impressive piece of work. So Gary and Alistair, you've got the endorsement you're seeking today from this board, and we look forward to receiving the updates and refresh and development as it goes forward. Thank you very much. Leads us nicely, Jerry, into your update on the new hospital programme, the Q3 report.
Good morning, and it's nice to be able to introduce this paper after the last 2 papers, because it really helps to set the context of the new hospital programme within all the opportunities that we have as a system. And again, I suppose the starting point is to really reflect that the new hospital programme is very much a system programme. It's an enabler that will help us to transform the care we provide for our population. But it is also very much dependent on and interdependent on how we work as a system in many other areas. If we're going to have the right hospitals for the future delivering the right care, it's very much dependent on our transformation of our digital agenda. It needs us to transform how we approach our population health, how we develop our integrated community structure, and how we work with our wider partners. So it is just worth stressing that the whole benefit of the new hospital programme is driven by and is part of the overall system programme across Lancashire and South Cumbria. The last 3 months has been a very significant part for the programme, and it's perhaps not reflected in the Q3 paper. So allow me, please, at least to perhaps update you on that. We've just been through a significant milestone of taking our long list of 10 options for the new hospital programme down towards a short list. That shortlist will be presented to the Strategic Commissioning Committee on the 10th of March, where it will formally endorse a shortlist of proposals. It's easy to say, but I can only stress there is a huge amount of work that's gone in behind that process, and we will therefore be able to make the shortlist public on the 10th of March. I'd like to take the opportunity to really thank all our clinicians, our staff, and our local populations who have really contributed towards the evidence that's helped us to undertake that shortlisting process. Looking forward, once the shortlist is announced on the 10th of March, we then really start going into a session where we start to bring alive our shortlist, really start to be able to articulate what it presents as an opportunity for our population, for our staff for the future. We will be building much more detail behind the options, and that will require us to really work closely with the Provider Collaborative Board and with our clinicians around our clinical strategy. It's also interesting to reflect on the work we continue to do with the national team around how they are seeing the new hospital programme develop. I can't underestimate or undervalue the amount of work the national team are doing now around looking at what does a modern designed hospital look like, how are wards constructed, how do people move through a hospital, how do we really use digital technology to change the way we provide and improve care in our hospitals. So it really is a fascinating, challenging, interesting programme in terms of the level of work that we have the opportunity to take forward here in Lancashire and South Cumbria, but also how we work with the national team in terms of looking at this from a national perspective. Listening to the last two presentations, there's been several times people raised the question about the wider partnership. And while we talk about the new hospitals programme, very much in the context of new hospitals, it is very much a programme that offers a much wider system benefit. We've been very keen to stress the wider system benefits of the new hospital programme. We've had very productive conversations now with the universities around the potential partnership with the universities, talking about research, education opportunities. We continue to work, and a big thanks to our local authorities for working with us to explore opportunities there, and also really starting early but tentative discussions with things like the local enterprise partnership around wider benefits of new hospital programmes to our local communities. At the heart of this, of course, though, is the care that the new hospital programmes inspire. So a big part of the next phase will be continuing to work with our staff, our lead clinicians, and with our public to talk about how do the new hospitals really change the way that care is provided. How do we really explore the benefits of digital technology, new medical procedures, medical technologies, and how they might impact the way that we can provide care in the future. So it's been a very busy 3 months past, and we're entering into an equally busy next 3 months in terms of the programme. I remain very confident in terms of the progress of the programme, and very happy to take any questions. Thank you, Chair.
Thanks, Jerry. I completely appreciate where we're at in the process, and that we get to shortlist. But your paper's a bit of a teaser for people, really, about what the shortlist is going to be. When will we be able to have that? When will that work be complete, and we'll be able to have that discussion?
So just to confirm again, the shortlist proposal recommendations go to the Strategic Commissioning Committee on the 10th of March. And it is that point we will make it in the public domain. And after that date, I'm very happy to come back and talk more around that shortlist of options and how we'll be progressing them.
OK, thank you. Any points or questions for Jerry, please? Trish.
Thanks, David. If you wouldn't mind, it's just a general comment I want to make, really, probably on the last three papers. So I'm sitting back listening to the conversation, and obviously the documents, and just to say that last document was fantastic. But my reflection really is, so this transformational change that we're just about to go through is enormous, and I say this with the spirit it's meant. I look around the screen, I include myself on this. For many of us, it'll be the last biggest transformation piece we're involved in our careers. So I just say that in the light of that. but so, you know, we are the custodians of this, really, to get it right. So, and, you know, it never ceases to amaze me, even, you know, when I'm sitting in Blackpool Foundation Trust or on the biggest, just, you know, how we're managing just to progress all this stuff, because it's enormous and we shouldn't underestimate it. So I guess I'm just reflecting, really, you know, for us to think about moving forward. So there's a lot of discussion about what we're going to do, but as important is how we're going to do it, and thinking about for any of this to actually come alive and be real and be sustainable and be legacy stuff, you know, really thinking about collectively how we're going to bring our staff, our workforce, our beleaguered workforce in a post-COVID pandemic. How do we bring them, our patients, our service users and our population? And it was really good to hear Jerry saying about the amount of time that's being spent with staff engagement and service user engagement. But I think we as a collective need to be always sense checking ourselves on the biggest picture, that as we're going through this transformational change, that we feel comfortable and sure that we're not always going to bring everyone with us, we know that, but we feel we're doing the right things in terms of checkpoints, engagement, co-production. I just wanted to make that point, because it never ceases to amaze me, the amount of the amount of transformation ahead of us.
Thank you, Trish. I agree. You referenced the last document, the photograph of the atrium in Blackpool Hospital looks very quiet on that photo. I'm not sure what time of day that was taken. Jackie.
Yeah, I completely agree with Trish. We've got some massive transformation ahead of us. But David, I just wanted to assure the board, really, that similarly to the new hospitals programme, we've obviously got Shaping Care Together, which really is being managed through Cheshire and Mersey, but is about Ormskirk Hospital and will affect you know, some of our residents in Lancashire, in West Lancashire in particular. But just that we continue to work with Jerry with the timescales. We're perhaps with Shaping Care Together slightly behind where the new hospitals programme is, but we continue to meet. We understand where we are, and we as you said, await with bated breath what the shortlisted options might be. But I think we're both going, aren't we, Jerry, to the Health Overview and Scrutiny Committee imminently. David, we're going to sort of give a very joined up, I think, integrated approach to how we're landing this. And I suppose I would just ask the board if in due course it would like an update on that Shaping Care Together scheme as well, so that you're sighted on what's happening over there as well.
Thank you, Jackie. Well done. Yeah, we would like to see that. That'd be very good. We'll schedule that for future. Thank you. And Andrew.
Thank you, Jerry, for a really helpful update. I think you mentioned some of the broader opportunities here around technology, jobs, transformation, and you also mentioned the fact that, you know, with a number of us, you've been having the dialogue with a local enterprise partnership about the connections between their strategy and this programme. And I wonder at some stage, Chair, whether we might want to invite colleagues from the local enterprise partnership to give us a view on some of this from their perspective, because we inevitably will take some of this from the perspective of our links with the national team, the work with the trust boards and the commissioning committee, but just to appreciate how other partners might look at this in terms of innovation, jobs, creation, employment. It probably ends up, again, as one or two other people have said, as part of the agenda that the ICP will concern itself with. But I think sometimes just hearing some of the opportunity from other perspectives might be encouraging and motivating for us.
That's a very good idea, Andrew. Let's follow through with that, please. And Jane?
Thanks, Chair. It almost follows up on Andrew's point, and I agree with Trish. The people with maturity of career, in order to be decision makers, it will probably be in the sunsets of their careers. And I know that we're trying really hard to engage with citizens, but I'd like to see us engage a bit more with early career health professionals, junior doctors, newly qualified nurses, newly qualified physios and the like. I think they'd have something really valuable to offer.
Thanks, Jane. Very good point. Right, Jerry. Anything you want to say coming back? Report noted. Sense of anticipation raised.
Indeed, and I look forward to coming back in the next quarter with a further update. Thank you, Chair.
Thank you, Jerry. And on the pulling together points that Trish has made and Andrew and Jane and others, that somehow we need to create the right place, Andrew, I think, for that bigger discussion about trying to keep an eye on the whole picture across the region. Thank you. Right, where am I now? Mental health, learning disability, autism system transition board. I know for very good reason Steve Christian can't join us just yet. He might join later, but Andrew, can you take us into this paper, please?
I could, David, certainly, but I wonder whether I could just do the item 9 paper briefly beforehand, because in a sense that will be our broad overview, and then
yeah, my mistake, Andrew. Yeah,
would that be okay?
Yeah,
if I do that, and it may be that Steve arrives with us in that time. I'm not sure. Thank you. Okay, so in terms of introducing item 9, this is our regular update we provide to the board on our very broad-ranging system reform programme. I hope that the paper is self-explanatory. I've already mentioned the publication of the white paper on health and social care integration. There is a summary of the main proposals in the document. There is a slide set from page 116 onwards, where you can again see the main areas of proposals, and then also see the consultation questions that have been asked by national colleagues. I think people may draw out a number of elements in there. For me, a couple of things really. One, a desire of the national team or national policymakers to talk about outcomes and the outcomes of integration. So clearly wanting to talk further about how we measure whether the approaches that we're taking deliver better outcomes, and the balance between nationally set outcome measures and locally set outcome measures. So I think that's quite an important area for us. Feels like it'll be one of the developing stories for 22-23. The other obvious point in the white paper is the importance of place and place-based accountability, place-based decision making. At this point, we think there's a good correlation between the proposals in the white paper and the work that we have already done in our system, and we give some indication of why we hold that view when you read between page 110 and 111 in the pack. So the work that we've done around place partnerships that Jeff has brought through the board on a number of occasions, we think there's a good correlation there. In his opening remarks, David made mention of the change in the timeline because of the airtime, the air cover they wanted to give to completing the legislation. So we're really conscious of that. We've had to review a number of our plans. We've rechecked our readiness to operate statements that are part of the critical path that we've used as part as preparing for the reforms. But again, as we said earlier, very conscious that aspects of this remain subject to legislation. So we will have to respond to that during the Q1 of 22-23. In relation to the integrated care partnership, we've mentioned it 2 or 3 times this morning now. We obviously had the paper that Angie Ridgewell sponsored in our last informal meeting, which has given us some clear principles to do further work, a sense that we want the ICP to be a different type of mechanism, a different type of group. We've had some further task and finish group time together, and we're now going to do some more work which we can bring back to system leaders in April, I would expect, just to build on the earlier work that the board has seen. Within the document, finally, there is a short update on the work of the Provider Collaboration Board. Again, some tantalising statements about clinical vision that's coming through the PCB's governance arrangements. We're looking forward to seeing some of that because it opens up the possibilities of provider collaboration across the system, but also is an important marker of how large providers will work with primary, community and voluntary sector providers when we start to look at some of the end-to-end pathway issues that are notable for us. So I think we'll begin to see that area of work unpacking in the next few months. So I hope the paper was helpful. It does give you the update. Happy to take any questions.
Thanks, Andrew. Any questions, Ian?
Yes, thank you, Chair. Thank you, Andrew. Very helpful paper that. You set out on page 7 place-based leadership roles. It seems that these have now been impacted by the white paper requirements for place and strengthening the role of place within the system. Can you just talk us a little bit through your thoughts on how that is going to impact the sort of people that we need to get involved in the place-based leadership roles?
Yes, certainly. So we've said for a number of months that we expected, whilst we would have a single integrated care board, that we would have a really effective place-based partnership in our 5 areas, and the ICB is one of the partners in each place. We've talked about the leaders in the places obviously coming together to agree a way of working that enables that place to proceed. And again, we've spoken of an executive level member of the Integrated Care Board being a local lead as part of that place and having a team to enable them to do that. So Ian, in the last 6 weeks or so, we've developed a clearer role profile for that leadership role, based on some of the work that we've done locally, but also based on some of the national guidance, including Thriving Places. Our thinking now, having had some very helpful opportunity of talking to our local authority chief execs, is that lead role would have a dual accountability. So they'd have an accountability to Kevin Lavery as our ICB chief exec designate, and they'd have a dual accountability to a local authority chief exec. And we're hoping that therefore begins to really create an integrated approach to leadership in place. They can't do it on their own, they can't do it without a team, and they can't do it without an effective partnership. But this is why I think, again, I'm saying I think there's a good correlation between this notion in the white paper of accountability in place and some of the thinking that we've done around those place roles. Kevin Lavery, I think, acknowledges he's had some discussion with us about this, even before he started, that this is going to be a role that we establish, but then will inevitably evolve. So I think, again, it's part of that sense of evolving leadership and partnership in place. I hope that's a reasonable answer to the question at this stage.
Thanks, Andrew. Any other points for Andrew? Good, all very clear. Excellent. Right. Are you happy to take us forward on the mental health paper, Andrew?
Well, I'm even happier, David, that Steve Christian's been able to join us. Oh. So if I let him start, and I may just add a little extra when he finishes. Thank you.
OK, Steve, welcome. Over to you.
Morning, Chair. Morning, colleagues. Thank you for having me today and this morning. So the purpose of the paper is to provide an update to the board in relation to progress that's being made in regards to mental health, learning disabilities and autism system transition board. And it'd be great today to give you an update and then seek any feedback or views from board members. So first and foremost, I'll take the report as read, but I'll just pick out some key points that I'd like to raise with colleagues. So in the first instance, be helpful just to maybe give a bit of background here. So as the paper notes, the ICS in early 2021, we commenced work with system partners across health and care to consider and facilitate the co-production of a roadmap to guide the future forward view in regards to system transformation for mental health, learning disabilities and autism services. That process was pretty diligent. It involved 40 structured interviews with senior representatives across the ICS, NHS providers, local authorities, CCGs and the VCFSE sector. And the structured interviews and the diagnostic allowed us to outline a report which identified key priorities for action, whereby we come together as a system to implement over the next many years to come. So to drive this work, we've established what's called the System Transition Board. That's chaired diligently by our Isla Wilson, who's an ICS non-executive director, I think is on the call. Note the notion diligent, please, Isla. And the representatives of those membership is cross the system. So we've got NHS local authority, VCFSE and primary care partners working together on the roadmap to support delivery against the key priority actions that were set out within the diagnostic work that we've done together as a system. So the System Transition Board oversees a number of quite exciting and innovative objectives in line with, I think, national good practice. And indeed, it hopefully will support Lancashire and South Cumbria pioneering good practice that we can share up and down the country. And today I'm just going to talk a little bit more about two key areas, two key strands of work. So the first key area is the changing landscape in regards to commissioning arrangements for mental health, learning disabilities and autism. As colleagues may be aware, and the paper points out, the national policy in England means that NHS provider trusts have very recently taken on commissioning responsibility from NHSE in relation to a number of specialist mental health services. So what does that mean here? So locally, Lancashire South Cumbria NHS Foundation Trust, LSCFT, is now buying and planning these specialist services. So LSCFT, as the lead provider, is now accountable for service quality and health outcomes. Working with the System Transition Board, we've now looking at plans to extend the lead provider model to further to include services that are currently commissioned by the area's clinical commissioning groups, CCGs. Therefore, LSCFT would be contracted by NHS Lancashire South Cumbria ICB. And the plan would be that we would take on those local commissioning arrangements in shadow form, LSCFT, in partnership with the ICB and our wider partners during 22-23, with an expectation that go live happens from April 23. To deliver and support this work, we've developed a Commissioning for the Future project group that reports into the System Transition Board. That membership is diverse, with existing CCG teams in, ICS colleagues, local authority and NHS provider members, to really start looking at the target operating model that we would test out in a safe environment through shadow form over 22-23. We've engaged Value Circle that are helping us facilitate some of this work. So we've got some real transparency and a real independence to check in, challenging our thinking to support the best model that will deliver the outcomes that we want for our Lancashire South Cumbria community. And page 128 and 129 just covers the benefits of the lead provider model and the future ambitions that I think that this opportunity gives us as a system. But personally, I think there's a real great chance here to look at the lead provider being able to work at scale with access and influence at system level, but can also and importantly operate flexibly at place to support local planning integration and integration of services to ensure that we get it right for those local communities and partners, because we know one size won't fit all. So setting standards and outcomes at system level, but really working at place to ensure that we plan, deliver and integrate services that deliver best outcomes for those communities. In the lead provider discussions currently, what I would say is there's a lot of excitement and enthusiasm from the professionals and clinicians that we're working with here. And people are really embracing this as an opportunity and taking collective ownership on putting together the target operating model that we want to test out through shadow form. So that's really exciting and quite positive. The second key strand of work is the creation of the Mental Health, Learning Disability and Autism Provider Alliance. So what do we mean by this? So with mental health in particular, we know that mental health is affected by not just health determinants, but more wider, including housing, education, employment and social isolation. So it's vital through the Provider Alliance we're looking to develop here that we include all relevant agencies to work together to effectively coordinate and support better mental health outcomes for our communities. So the aims of the Provider Alliance, which we are looking to test and develop through spring, early summer, is to bring those agencies together to really look at how we can make joint decisions through the lead provider model about how we organise our services to benefit the populations that we serve. as I've said in the paper, I think the Alliance provides an excellent mechanism for the lead provider model for commissioning to ensure that we set the right commissioning intentions and we work with across health and care to support system-wide transformation so we can really understand and plan population health management and tackle the inequity that we know we've got in pockets of our system. The paper, I won't go through the detail, but it describes the governance in relation to the 3 subgroups that we're looking to achieve and deliver. The important element behind this is the partnership. So it's not NHS led, it's joint led, and each of those transformation groups, and there's 3 in total, will have a director of adult social care and an NHS lead director and a primary care lead as a triumvirate trio model leading each transformation programme with a wider community. So it's a real coalition of an alliance to drive delivery and ambitions through our transformation. The starting point behind this, and Alex Heritage is on the call representing Caroline Donovan, is development of the system-wide strategies for each of the transformation groups. And over the course of this year, we've really engaged in a programme that's got a vast level of membership that's supported co-design of this work. So a number of workshops have been in place. We've engaged with over 80 health and care providers across Lancashire, South Cumbria, alongside service user groups, where we're looking to determine the strategy that we collectively own and can sign off. And then the transformation groups that I've made reference to in the paper will support on deploying and delivering against the priority actions set out within the strategies that we've developed together as a system. Under 130, there's an array of benefits that we've put forward in developing the Alliance and some of the intentions and outcomes we're looking to deliver over this next period of time. For me personally, I think it's a great opportunity to look at how a group of providers can look at levelling up quality across Lancashire, South Cumbria, so that we can ensure there's a consistency of the best experience no matter where any member of our community lives. Within the paper, there's an example in relation to transformation at scale and how we as partners are starting to embrace this alliance working in our collaboration. I won't go through its detail, it's noted in the report, but it makes reference to the community mental health transformation work, which is the single biggest NHS investment in mental health services in recent times. And LSCFT, as the lead provider, as the host for this work, is working with its provider alliance to ensure that we deliver against the ambitions we've set out within this programme, which we talked to in the report. So in conclusion, it's a really exciting time in mental health, learning disabilities and autism. We've set out the governance and some of the architecture, but more importantly, we've created a real movement and a real positive cultural shift in collaboration and partnership. We've made some commitments to one another and we're now working through our delivery. At this stage, I'm happy to take any questions from colleagues and thank you for your time.
Thank you, Steve. A good paper, well presented. Got Mike, then Isla.
Thank you very much. From where I'm coming from, I'm looking at this from the other end of the telescope. I called in yesterday at the Asylum and Refugee Centre in Blackburn. I'm also in touch with a church in Chorley, which provides a free hot meal every Monday night and offers food and sanitary products, for which there's a great demand, helping to relieve the stress and anxiety of families in desperate need. It runs a debt crisis centre and a cafe open every weekday where people are asked to pay only what they can afford. And there's no need for me to say how this mental health tsunami is affecting people who use that kind of facility. The challenges are huge and growing, not just from the pandemic, but anxieties about Ukraine and global warming and everything else. Just as I was leaving the refugee centre, in came 2 NHS nurses offering TB screening to those in the drop-in rooms. And the parish priest of Chorley has emailed me to say, our doors are open literally for everyone in the community of faith or no faith. We're beginning to develop our hospitality further to include art and music therapy. With our partners, we continue to offer a safe space where people can find friendship and opportunities and flourish. It is enormously encouraging to see that the Trust is intending to work with local communities to make its services more accessible. I sincerely hope that they will be not offered exclusively in NHS premises, but where people actually are. It's exactly where these faith communities are, where the voluntary sector flourishes. And so it is really heartwarming to see this report literally peppered with references to the VCF sector. Thank you for all of that. And please let your professionals work with us where the people are.
Thank you, Mike.
Thank you.
Isla, then Jane, please.
Thank you. So I want to just I want to just draw our attention to a couple of pieces of this. This has been a very, very tricky programme in lots of ways, and we could talk about what's been tricky about it for some time. But there are some elements of this that have gone extremely well, partly through that learning. And I want to just draw the board's attention to those, because I think there are some models here which we could apply elsewhere. So the first of those, I just want us all to really notice that we now have system-wide strategies for mental health, learning disability and autism. That is not something we've previously had, and has been enormously helpful in pushing this work forward, because we now have shared objectives to deliver against. Within that, and kind of beyond that, the model that Steve described of co-leadership between the NHS and local authority, whilst initially had some challenges, has produced really good results, and is something that I think we should consider using much more broadly. That's really helped develop a shared understanding of services and the challenges. This is a very wide system-based approach, so there is lots of voluntary sector involvement, lots of community buildings in use, Mike, you'll be pleased to hear, and also broad engagement with people who use services and their advocates. This will be a provider collaborative that sits not just in the NHS, and I think that's really important when we think about what integration means for us. So I think that there's things there that we can draw on and that we can use more broadly. What I would also say, that as we move forward with those two strands, the provider collaboration and the new models of commissioning, there are still organisations in the system who have been less involved in that work. It is a huge opportunity for us to do things very radically different. And my plea is, if you're not currently engaged in that work and you are interested in it, please come alongside this work now, because what we've learned so far is the sooner people are involved in the conversation, the easier it is to find a way of delivering the strategy that works for the outcomes we're doing. So we are committing to putting things in with 6 weeks minimum notice so that people can be involved. We're trying as hard as we can to have everybody around the table, but for the next stage in particular, that is going to become incredibly important to the future success of this programme.
Absolutely, thank you, Isla. I've got Jane then, Jeff.
Thanks, Steve. Great paper. I confess I'm a little anxious that I can't see any reference to perinatal mental health in this paper. Something between 10 and 30% of women are affected by postnatal illness, managed largely by primary care and community mental health services. Can I seek some assurance, please, or can I commend to you that you join up with Maternity Voices Partnerships and the local maternity neonatal system, because I can't see a reference and it makes me anxious.
Steve, you want to come back on this Jane's point, please?
Thank you, Chair. Jane, yeah, I can give you that assurance that that services are indeed in scope as part of our programme. But what would be great, Jane, is following boards, we'll connect and we'll talk it through, if that's okay, Jane. I'd really welcome your views, actually. So thank you.
Thank you.
Jeff, then Jackie. Yeah, Jeff.
Microphone off. There you go. Sorry about that. Start again. Thanks, Chair, and good to see you, Steve. It's an enormous transformation programme, and I'm not well sighted on it, which is fine because I can't be involved in everything at place where I come from. So I have to trust the people in my place, you know, which would be who you will know, Jim Hacking and Liz Dover, and I'm assuming they've been involved in this programme and they're comfortable with it. So that's a yes or a no. And the second question, and I'm assuming it's a yes, it must be, but the second question is, so in my work around place-based partnership development, I need to understand you know, if you're setting standards across the system, which is fine, and managing things across the system to be uniform and quality and everything else, what's the role of place, and how will place function around tailoring this? Because I need to be comfortable that actually there is a role for place here, because it sounds very much like this is what we'll do. And I don't think that's how you operate. I know you operate on a place-based model. So could you just say a few words, a yes or no to the first bit, and then a few words around how place will shape this and function with this?
Yeah. So first question, yes. Can I put? I just want to further endorse Dr. Jim Hacking in particular. So Jim's been integral to our architecture and design of the current arrangements. So thanks. I must note Jim's contribution, and please reference that, Jeff, and feed that back. In relation to the second point, I'm going to be quite open and vulnerable here, Jeff, in that we're on a journey. We've developed the Commissioning for the Future group, which has got representation from both place and the existing CCG teams, and we're working together on some of the shared principles we've developed. That some of them are set out in the report, and we're now through the target operating model development working together to determine the future state. So there's no predetermined model. We're now entering a 6 to 8 week process where the place, CCG and ICS and LSCFT colleagues are working together through the facilitation of the value circle to work through what does this look like and what does it mean. The commitment that I would like to give now, and it's part of our principles, is that we've got to deliver service and plan and transform at place. So whilst we may set scalability at system, we've got to do it at place, and the operating model has got to absolutely recognise that and deliver and drive that ambition. So, Jeff, it's probably given confidence that we've got engagement with all the right people in the room, and we're now on the journey of developing the model together. And we'll probably come back to share that with colleagues via the system transition board, if that's okay.
Thank you.
Thanks.
Jackie, then Andrew.
I suppose mine's something very similar really to what Jeff's just raised. You know, in terms of place, we are also obviously, you know, trying to engage with housing, with our local authority colleagues. And I suppose I'm quite conscious that we are not pulling them in all different directions, and we're quite clear how we're using them. And obviously for us, you know, as we look at some of our residents, we can't look at sort of mental health in its silo, because we've got debt, we've got economic regeneration. There's lots of things out there that impact people's lives that puts them in. And I suppose I would do the same. I would ask maybe that some of the place-based programme managers come and have a look and talk through this model that you've got, really, Steve, just to try and understand, you know, what we're trying to develop at place, what you're trying to develop there, and how we could work together. So I'd be very happy to facilitate that if you'd like me to.
Yeah, thanks, Chair. Briefly, thanks, Jackie. Take those points forward. It was only last night I was meeting with a selection of place leaders, working this through and talking to colleagues about how we do this together. So we're working with Victoria Ellaby and the place leaders, and I'm now part of I'm part of forums that will engage all colleagues and update colleagues in the discussions, but allow people to have a view and support in future developments. So and the other 2 points I can completely concur with and support. Thank you.
And Andrew.
Thank you. Just a couple of next steps, really. In terms of the system-wide strategies, I am liaising with Alex to make sure that we can receive those at the Strategic Commissioning Committee, because I think we need to endorse them when they are completed. And I suggest that they also need to be endorsed within local authority or health and wellbeing structures. They've been co-led, as Steve has said, and I think that's quite an important marker for the partnership and some of these models that we're developing. We are definitely learning as we go with this piece of work. It's not without risk, and you've just explored that in relation to the place-based dimensions, which are going to carry on being worked through. The other element of it that's not so much in the paper is the relationship between a lead provider and the ICB once the ICB is established. And I think within this idea of a shadow year, the accountability arrangements between the ICB and a lead arrangement need to be finessed. We haven't done that in any detail yet, so that's work to be done. And I think it's obvious from a number of the comments made, the test of this is the outcomes. 3 years ago, we were in a really difficult position in relation to aspects of the mental health system, its urgent and emergency care performance and the way it was letting people down. There's been an awful lot of work and improvement done since then, but we're still, as Mike was saying, we're still facing major issues in people's lives, in people's mental health, that require a multi-agency response. So we will need to pay attention to this over the next 12 months to make sure the outcomes we're thinking through, and they're in the paper, we realise them. Thanks.
Thanks, Andrew. So, Steve, some challenge, lot of support, good suggestions in terms of next stages of process. I think the place engagement bit that Jeff and Jackie have raised is vitally important for us, for this piece of work, but for the system more broadly in terms of thinking of the next stage of development. So thank you very much and well done. We look forward to receiving an update from you in due course.
Thank you, Chair.
With 2 papers to note, items 11 and 12, the System Development Programme and the Health and Care Partnership Summary Reports. There's a number of items that have emerged from our discussion today which populate future agendas. We meet again in formal session on the 4th of May. I've not been notified of any items of any other business, so thank you all very much indeed for the contributions today. A lot of important things for us to think about as we go forward from here collectively and individually. I'm sure along with me a number of members of this board will be reflecting very much on Jane Scattergood's point about the sunset of our careers. So thank you, Jane, for that, and thank you all for your contributions. I very much look forward to seeing you all next time.